A patient sits in a clinic experiencing severe, unrelenting pain. The soles of their feet feel like they are on fire. The simple weight of a bedsheet feels like sandpaper against their skin. When they stand up, their blood pressure drops so rapidly they nearly faint. Desperate for answers, they finally see a neurologist. The physician runs the gold standard diagnostic tool, a nerve conduction study, and an electromyography, or EMG. A week later, the results come back. They are entirely normal. The patient is explicitly told their nerves are fine, even as their physical agony and autonomic failures escalate. They leave the office feeling dismissed, convinced that their symptoms are either a medical mystery or entirely in their head. But the clinical conclusion is flawed. A normal EMG does not mean the patient is free of nerve damage. It specifically proves there is no damage to the large nerve fibers. The test is physically incapable of detecting damage to an entirely different class of nerves. Small fiber neuropathy is a distinct pathological disorder hiding in plain sight. To understand it, we have to look at the microscopic anatomy of why standard diagnostic tools are blind to it, how undetected metabolic dysfunction drives the nerve damage, and the precise clinical protocols required to finally detect it. A peripheral nerve is not a single uniform cable. It is a bundle containing distinct nerve fibers of varying sizes and physical structures, each assigned a completely different biological job. The large A-alpha and A-beta fibers are wrapped in thick myelin sheaths. These are the heavy-duty cables responsible for carrying vibration, position sense, and motor signals back and forth from the brain. Standard EMG equipment is designed to fire electrical pulses that travel along these massive, fast cables. But there are much smaller targets inside the bundle. The thinly myelinated A-delta fibers transmit fast, acute pain and cold sensation. Even smaller are the tiny, completely unmyelinated C fibers, which carry burning pain, warmth, and autonomic signals. Because these small fibers lack thick myelin, their electrical signals conduct slowly and weakly. They do not generate enough voltage to register. The machines are physically blind to them. This creates a distinct clinical timeline. Large fiber damage often presents quietly as a loss of sensation, but early damage to the small fibers is loud. It produces intense burning, hyperalgesia, and allodynia, where even light touch triggers exaggerated pain. Because standard diagnostics look only at the large cables, patients with pure small fiber neuropathy will produce normal test results while suffering extreme symptoms. Unmyelinated C fibers also form the architecture of the autonomic nervous system, the automatic controls for your internal organs. When these fibers fail, the body loses pseudomotor function, causing patients to experience either total lack of sweat or severe oversweating in their feet. Cardiovascular regulation is compromised, leading to rapid heart rates, palpitations, and severe drops in blood pressure. The enteric nerves controlling digestion are also affected. Patients frequently experience nausea, premature fullness, and severe constipation, symptoms that are routinely misdiagnosed as irritable bowel syndrome. These are not disconnected organ diseases. They are all manifestations of a single microscopic neurological root cause, the failure of small nerve fibers. To objectively prove this damage exists, clinicians must utilize the actual gold standard, a skin punch biopsy assessing intraepidermal nerve fiber density. A laboratory physically counts the tiny nerve fibers reaching into the epidermis. Because fiber density naturally declines with age, this count is mapped against strict age and sex-matched normative data to confirm the diagnosis. This is supported by additional diagnostic tools. Quantitative sensory testing measures warm and cold pain thresholds, while QSART measures sweat nerve function, evaluating the extent of autonomic failure. The physical distribution of the pain maps the underlying pathology. Symptoms beginning in the feet and climbing upward suggest a length-dependent dying back process. Patchy distribution on the face or trunk suggests a non-length-dependent pattern, often driven by a systemic immune attack or a genetic cause. Up to 11.6% of patients with pure small fiber neuropathy carry pathogenic variants in voltage-gated sodium channels, specifically SCN9A, 10A, or 11A. Identifying these specific mutations can fundamentally change the treatment approach. Small fiber neuropathy is not a mysterious, unprovable condition. It is objectively verifiable once a clinician abandons the EMG in favor of correct tissue assays. Historically, up to 70% of cases were labeled idiopathic, meaning the cause was unknown. Today, systematic evaluation reveals hidden drivers, most notably type 2 diabetes or autoimmune mimics like Sjogren's syndrome, celiac disease, and lupus. More critically, small fiber damage is often the earliest detectable sign of glucose dysmetabolism, appearing long before a patient meets the official clinical definition of diabetes. Standard metabolic screening misses this window. A patient can have normal fasting glucose and a perfect A1C, while still experiencing severe post-meal glucose spikes and high insulin levels that destroy nerve tissue. To expose this instability, a 2-hour oral glucose tolerance test is required. By forcing the body to process a precise glucose load, clinicians can reveal the hidden dysmetabolism that fasting blood work conceals. Insulin resistance and dyslipidemia, specifically low HDL cholesterol and high triglycerides, also independently correlate with a reduction in nerve fiber density, completely separate from blood sugar levels. At the cellular level, hyperglycemia and lipotoxicity generate reactive oxygen species and advanced glycation end products. These toxic compounds accumulate in the nerve tissue, trigger localized inflammation, and choke off the microvascular blood supply to the high-demand mitochondria inside the small fibers. This metabolic dysfunction quietly destroys the peripheral nervous system at a cellular level for years before standard blood panels ring the alarm. Treating the resulting pain is not the same as treating the disease. Highly prescribed neuropathic medications like pregabalin or duloxetine can mask the pain, but they do absolutely nothing to alter the underlying disease course. The clinical evidence for reversibility is encouraging. Correcting insulin resistance, normalizing glucose, and implementing supervised exercise have been shown to physically increase nerve fiber density over a 12-month period. Patients require a structured framework for evaluation. Documenting sensory burning alongside autonomic symptoms like sudden dizziness or digestive failure establishes the clinical pattern. This justifies ordering the specific diagnostic labs: a glucose tolerance test, fasting insulin, B12, and an autoimmune panel. If an EMG returns normal while these symptoms persist, the evaluation is not over. That is the moment to systematically advocate for an OGTT and a skin biopsy to uncover the true cause of the damage. Peripheral nerves act as sensitive biological markers for systemic metabolic health. By acting on small fiber symptoms early, even when an EMG is normal, patients can address the underlying damage before it involves the large fibers and leads to permanent loss of function.